Good evening, everyone, and thank you for joining us for tonight's clinical webcast, Tips for Practice Building with your Keratograph 5M. Before we get started, I'd like to point out that you have a text box on the right side of your screen, and you can ask questions there or leave comments, and we'll conclude tonight's session with a Q&A. Joining me tonight is Dr. Chad Overman. Dr. Overman is a consultant to OCULUS, and his insights and experience have proven to be quite valuable for OCULUS and many of OCULUS's customers in understanding how technology like the Keratograph 5M can be better utilized in an optometric practice to improve patient care and the financial well-being of the practice. So I'm certainly grateful that Dr. Overman accepted our invitation to be our guest speaker tonight and share some of his wisdom. So without further delay, I'd like to welcome Dr. Chad Overman.
Thanks, Chris. I appreciate your offer. I appreciate everybody that's on, and I think from the last year and a half of working with Oculus and learning about the Keratograph 5M, being in lots of practices, I think we'll have some things to share, and I look forward to the questions towards the end. So we're going to be talking about some best practices that I've learned, and we'll go through a few things. Some of the science part a little quicker than others, but I want to spend some time today talking first about some of the things that I've learned, but we'll go over a little bit of the disease process first, and then we'll go through that kind of fast and then get more to what I'd like to talk about and teach you about your dry eye clinic possibilities. So we've all understood what dry eye, that it is a multifactorial disease. The part that I'd like to really focus on is more the dysfunction of the tear film. Osmolarity and inflammation is extremely important. I think those of you on the webinar that currently have a keratograph, you'll agree with me. I think that the keratograph is really the cornerstone of the dry eye clinic, and we'll be able to go through some of that tonight and show you and then others that do not have a keratograph how they could be using it to maximize both the patient care and the practice care part of it. So let's move on to the next study, the aqueous versus evaporative. I think it's extremely important that we be able to tell the difference. So when we get to our treatment plan, so that's something that we'll cover a little bit today. As this slide shows, it's a lot more evaporative than aqueous deficient, but we need to know the differences, and I'll show you how you can help find that. So the quantity of the tear film layer, we've all seen these ways that you can do it. I don't think our patients like this very much. It's not really great from a practice perspective, reproducibility. So I think a benefit of the keratograph from a tear meniscus height standpoint is a much better way to assess the tear film quantity. It is non-invasive, it's very quick, and it's a whole lot better for our patients. So when you're looking here at the tear meniscus height, you're going to want a number between 0.2 and 0.4. It's going to let you know if there is not enough, if it's below 0.2. If it's above 0.4, then you have too many tears, and there may be other reasons that we need to look into. But I really like this as a starting test, and we'll go through many tests tonight that you can do with your K5. But this is one that I think is critical. Need to know if enough tears are there to begin with. So I'm going through these kind of quickly because I'm going to spend some time on some later slides that I feel is probably more of a reason that you've joined us tonight. So also, besides the quantity of tears, the quality of tears are extremely important. In this slide, you can see non-invasive tear breakup time. That is extremely important when it comes to what you can learn from a patient's dry eye state with the K5. You also can check the lipid layers to be able to tell the quality. And then below, we'll touch a little bit on some other testing that I believe you should do when you have a dry eye clinic, and the tear lab there is certainly important. So when you're setting up your dry eye clinic, I think it's essential that you use the non-invasive tear breakup time as a screening tool. This is a tool with the Keratograph that will give you so much information, and it also gives the patient some information, because when a patient sees a picture like this, they can understand what the red means and what the orange means. And it's a great tool for you when you're talking to a patient. You can point out those locations. And what I start talking to patients about is, you brush your teeth every day, right? And they say yes. And I said, well, why do you brush your teeth every day? Well, it's to prevent cavities. And that's exactly how you can talk to a patient about this particular report. Is you can show them these red spots, these orange spots, and say, these are areas of your cornea that are drying out, and they're drawing out quicker than when you blink. So this particular spot, you can say, Mrs. Jones, this is a potential cavity, much like in your teeth, that I want to prevent. And Mrs. Jones is going to understand that what these spots are going to do by having that analogy. So I would run this particular screening on all of your patients that are contact lens wearers, and we'll go into a little bit more of that later. But it's extremely important to know is that I've tried every contact on the market on this patient, and those darn contact lens manufacturers just can't come up with a lens that will work, when really it's a tear film insufficiency problem. So I would run it on all of your contact lens wearers. I would say women over 40 and men over 50 is a great place to start. We see an awful lot of dry eye that will fall into those categories. So if you have a Keratograph and you're not screening more of these individuals, you have a huge opportunity. And these are patients that are coming in every day that could use some help and could be put into your dry eye clinic. And so think about doing a screening on all of those individuals. We've got a protocol that has been written, so at your request, we could certainly send that to you and go into that, but those are some of the things that I've talked about in that protocol as well. So keep in mind the NIKBUT. That's extremely important to your dry eye practice. So also, this is very important, when Mrs. Jones comes back, you can show a comparison of her previous NIKBUT compared to what it was a year ago, 6 months ago. You can line these up and really use it to get her to understand that she needs to follow and be compliant with your treatment plan. It's kind of like the dentist, you know, you floss your teeth before you go to the dentist, but you know, oftentimes he still knows that you just did it. Well, this will assure you, and it'll help Mrs. Jones see that you're able to follow her over time and see that the treatment is improving or not improving, so that you can tell, is she really following your treatment plan and being as compliant as she should be. So I love this aspect of the Keratograph, that I can pull up and show and be able to show right there in the examination room that, you know, Mrs. Jones, it looks like you're doing a good job. Things are improving, because oftentimes, you know, the symptoms haven't improved yet. Maybe on that first visit back, she's still complaining possibly about her symptoms, but you can show her, well, what you're doing is good. Keep up the good work, and it will keep her on the right track from a compliance standpoint. Now, the next test that I think is extremely important that the Keratograph provides for us for a dry eye clinic is the Meibomian glands. I know in the past, as I treated patients for dry eye, I may have suggested different heating options, maybe you know, warm compresses, and I never actually knew what the Meibomian glands looked like. So being able to see the Meibomian glands, be able to tell and show if there's dropout, and oftentimes I've watched that dropout show up exactly on the NIKBUT of where those dry places are. So it's going to give us the quality, you know, what kind of lipid layer are we getting out of there. Now, a great pearl that I think your technicians will be happy about is most of the time you can probably just do the lower lids in your practice. A lot of doctors ask me, you know, about the flow of the practice, and the technicians aren't always really good at performing an aversion of the upper lid. So once you get a good baseline on a patient, the follow-up visits that you have, you can certainly just do the lower lid, have the technicians do the lower lid. They'll be happy with you, and you'll still get the results that you need. But without this particular test, you know, how are we going to know if they have the dropout and to what severity it is? And then there's something that I really, really like that's been added fairly new, is this grading system for the Meibomian glands. You know, being able to line up, you know, this patient on the upper, you can see that dropout very easily. But when you can compare and you get an idea of where they're at, you can see what kind of dropout that you're dealing with, and that certainly can help with your treatment plan as well. So quantity is extremely important for the tears. Quality is extremely important with the tears. The ability to do all of this with one instrument is incredible, and I've been very happy, and all the doctors that I've been talking to is extremely happy with their dry eye clinics and the Keratograph. So you can watch here as well, the quality of the blink is extremely important. The Keratograph can take videos, and so you can look at these videos and see what the blink frequency is, and of course the quality of the tears being spread with the blink is very important as well. Now all of this can be put together in a dry eye report that is named JENVIS. It puts all of the information into one place, so it's very easy, and we're going to go through the JENVIS report in a few slides here because I think it's extremely important. It's going to help you be able to tell the severity, and you'll be able to track the progression of your patients. It definitely improves the workflow of a dry eye exam from your technician's standpoint, makes it much quicker, much easier. And then I'm going to spend a little time on the printout, because the printout I believe is extremely important. I'm going to cover that in some slides coming up and explain why I believe that. So here's a JENVIS report, and it's possible to make this your own. So you can decide, what you want to do. Is it, do you want to do the redness, which I haven't covered on this particular presentation, but you can have that on there. I believe the Meibography, the tear meniscus height, if you do an OSDI survey, that needs to go there. The NIKBUT is absolutely critical, but by putting it on this will grade it for you, and then it'll give this upper right picture that will help you on this particular patient, where are the problem areas? What do I need to focus on? So it's a very quick glimpse into what you need to do from your treatment plan. So let's move on to another view. This particular printout, I think, is one of the best things from a patient compliance standpoint. It's extremely important. You can put your logo here at the top, because I'm going to jump ahead on one of my slides. I'm going to talk to it now. This report is extremely important to the compliance of the patient. So I want you to print this out and give it to the patient. It's something they should go home with. You put your practice logo on here so that they remember you, and they've got your contact information, which is extremely important. You've got the grading scales here, so a patient can look at this and understand what they're looking at. Your recommendation is here. So when you're typing your recommendations, it will show up here on the printout. So that way, patients understand exactly what you've done, what your expectations are for them to do. And you've got up here, treatment for Meibomian gland dysfunction. They may not understand exactly what that is, but they understand what you want them to do, and they can go back to that. And quite often, you'll hear that the patients, or you'll see when you're doing this, that the patients will bring this back. They're very interested. If their non-invasive tear breakup time, was 4 seconds, they're very interested in what is it on the return. So oftentimes you'll see your printouts come back, and I think that's, again, very important from a compliance standpoint. And I'm going to talk a little bit later, we're talking a lot about patient care right now. I'm going to spend some time talking about your practice care. And part of that practice care, it's extremely important that patients are compliant to coming back to see you. We'll cover that a little more extensively later. The description of the tests, I've talked to quite a few patients, and oftentimes they'll leave their doctor, whatever type of doctor they're at, and they just don't understand exactly what you did or what they just went through. So I think this is extremely helpful to have the definitions here of the tests that you did. The patient will appreciate this part of it, because they'll take it back, and many times they're having to talk to a spouse or a family member of what happened, and they can hand this to them. So the JENVIS report, I think, is extremely important on the back end after you've done all of your testing, and it is for your patient as much as it is for you. It'll help you with your diagnosis and treatment plan as well. So here's where I jumped ahead. I do think you should send the patient home with the report. When I talk about your practice care, I put here it's okay to make money. And I've made that statement a few times to a few doctors that they seem to be reluctant to make money, and I've asked why, and they just feel that it's something that they're in practice for the patient care part of it, and I get it. But if you think about it, you do the procedures that you need to for the patient care side, and then you take care of the practice care part, then you have the money to go forth and do more things that can help the patient. So I think as a overall group, optometry has lagged behind a little bit in this particular aspect. So most of the rest of tonight, I'm going to spend more on your practice care. And again, starting with the premise, it's okay to make money because you are helping these people. So we'll spend some time there, and hopefully, you'll have some questions at the end. Now, here's a part that I was talking about earlier about contact lenses. It's just another area of some lost revenue that, realizing that a lot of these contact lens patients dropped out because of tear film insufficiency, you'll actually start to help these patients that once dropped out. Sometimes they didn't even tell you why, but as you're doing the non-invasive tear breakup time on these individuals and you're finding out that there's a lot of red, a lot of orange, there's some issues there, I think you should talk to all your patients about, would you like to wear contacts again? And the Keratograph will actually help you start realizing some of this revenue again as well, because now you have a diagnosis and you'll be able to show the patient, you'll be able to treat the patient, and then maybe after 6 months or so you'll have them back and you'll be able to put them back into contacts. So you can see here, and this was pulled from another location, but $267 is what each contact lens patient is worth to you. They do return more often. They also purchase glasses and sunglasses and solution if you sell that in your office. So that's a point of lost revenue that I want everybody to start thinking about, because there's an awful lot of our patients that have dropped out of contacts, and it is a dry eye issue. So by connecting that and taking care of that, you'll get the revenue back from some of these contact lenses as well. Now, this slide is more directly what you may want to, may have joined us tonight for. So I'll leave this up for a little bit if you want to take a picture of your screen, and we can certainly send it to you at some point as well. But as you walk through here, the Keratograph, the 92285, that's an anterior seg photo. And I've put on here that most of these tests you'd be doing 2 to 4 times per year, because it depends on the amount of time that you're having a patient back. But I believe at least 2 you're definitely going to have them return. But again, depending on the severity, could be up to 4 times. Tear lab and Inflamadry, if you do not have your CLIA waiver yet, you should reach out to one of these companies. They'll help you get your CLIA waiver. I think they're extremely important to the overall process. As I've said before, your dry eye clinic, I think the cornerstone is the Keratograph, but we need to put the tear lab and Inflamadry together with that so that we know the osmolarity. If the osmolarity is part of the issue, we can treat that. Good omega-3 is extremely good to drop that osmolarity good 10, 11 points in the first 2 weeks. Inflamadry, that I think is extremely important. I'm hopeful that Inflamadry or another company will come out with a little more a design that's a little easier to read and not just a positive or a negative sign. But I think it's extremely important. I can't tell you how many people I put in punctal plugs over the years that I probably made it worse because I didn't know I didn't have inflammatory. So how much inflammation was there, I didn't know. So is that something we need to get a steroid on board? That's a good question to have answered for you with the inflammatory. And, you know, both the tear lab and inflammatory, you're not going to necessarily make a lot of money per time on those because of the cost involved with it. The thing about the Keratograph that I like is it's not a per click fee. You own it. So it doesn't matter, you know, how many times that you actually use it, you'll realize that revenue off of it. But the Keratograph is so important to drive the tear lab and the inflammatory. So you need a reason to do those, and the Keratograph gives you a beautiful reason if you've got that NIKBUT already done and you've done the screenings. And then, of course, I'm sure you're all familiar with the punctal plugs and what's available from a reimbursement on that. The 92012 codes for the office visits, I've always asked each doctor I work with, you know, what's your office visit reimbursement, and 85 is kind of an average, is why I put that on here. This is extremely important. That's why I talk about the JENVIS report. So when we talk about practice care, I think this part is extremely important to get that individual to come back. We know we've had different diagnoses for patients, and you know, we tell them when they should come back, but they don't. So the JENVIS report, I think, is extremely valuable in getting those people to come back, and that drives your 92012 office visits, which again, very much helps your practice care. So each dry eye patient, I've got it listed here, the incremental income that you will make off of those is significant. You know, all of these numbers depend on, do you bring them back 2 times, 3 times, or 4 times? But on average, if you can diagnose 200 patients, you're going to increase your revenue here from $99,000 to $156,000. And I'll say that there's very few of you that couldn't put 200 patients into your dry eye clinic fairly quickly, especially if you're doing the screening. So the doctors that I've talked to that were having difficulties growing their dry eye practice, they weren't doing that as a screening, and so they weren't finding a lot of these patients that they really could put into their dry eye clinic. So 200 patients that are already coming through and sitting in your chair on a daily basis. You know, think about what your overall practice looks like, especially over 40, and then your contact lenses as well. It will not take that much, and there's no extra cost to find these. You're not having to go out and pay external advertising fees to get this. They're sitting there. And one doctor in particular, I was working with him, and he gave me a lot of his numbers. He had an incremental net of $94,000 in about 9 months, and all he did was really get that NIKBUT up and firing. So he was very good at printing out the report, but I think he's on his way well over 300 patients right now. So it's very exciting for me to work with all of you and give you some of these small but significant little pearls that will help you with your flow. I think a lot of doctors were having some issues with their flow because they weren't treating it as a screening on the front end. So it doesn't take very long to do the non-invasive tear breakup time. And then something I haven't touched on, once you identify that patient, you can have them in the chair and you can say, well, Mrs. Jones, you know, we're going to do a comprehensive eye exam on you today, but I see that, you know, from this picture, and you show them the picture of the NIKBUT, there is some additional testing we're going to need to do. And generally, a best practice is to set that patient up on a diagnostic schedule for yourself to do in 1 to 2 weeks. So then you can bring them back and do all of the other testing. So I think it's extremely important to do all of those tests that we talked about earlier, but you may not do them the very first day. So some of you might be having the question of, how am I going to do all of these tests? You're not going to do all of them right away. Do that screening with the non-invasive tear breakup and then bring them back, and that's when you're going to do all of the additional testing, and then you'll drive that JENVIS report through there. So I realize I hadn't really discussed that appropriately, but that may answer a few of your questions. So in summary, you can tell that I'm extremely happy with the K5 and dozens of practices that I've worked with. Some were successful right away, some needed a little bit of help, but by using the Keratograph, you really are able to help that patient, and you'll find out what type of dry eye, how bad is it, but then you'll be able to follow them and really be able to see if your treatment plan is working or not. I think I've said maybe a couple thousand times, it's nice to finally have science behind us. You know, previously when we had a dry eye patient, we would ask them, how do your eyes feel? Well, that's not very scientific, and we don't necessarily know what the patient did the day before, the night before. So having some science behind it, I do feel that we're truly taking better care of our patients. And then along with that, we're going to have the better practice care. And to be able to drive that incremental revenue, I think you're going to be extremely happy. For those of you that do not have a Keratograph yet, these are real numbers from real practices. And then those of you that have a Keratograph and aren't realizing those, I hope you take some of my discussion today, and if you have any questions about that, we can certainly get you some more information, and I'll be available to answer questions, of course, now too. So Chris, I know I covered an awful lot fairly quickly. People have busy lives. I appreciate that they're on. Is there an email or a phone number? There we go. That's what I was looking for.
Yeah,
Thank you.
Yeah, if you have any questions about the Keratograph or any Oculus products for that matter, you can contact us at the number here, the 1-800 number, or you can contact us always at sales@oculususa.com. If you missed part of tonight's webinar, or if you want to watch any recorded webinars from past lectures, you can go to our website, www.oculususa.com, and we have webinar archive if you go into the webcast section. We also have another website where you can see live lectures that have been performed at some of the various medical conventions at www.oculustv.com.